Good morning. My name is David Abear. I am the ECMO coordinator at Children's Hospital in New Orleans. It is a pleasure to be here with you guys and nice to see you guys in person again. New friends and old friends. It's really been interesting. So thank you for everyone for having me. We're going to talk next about adventures in ECMO with Bedside Essentials. As we know, every ECMO case is an adventure, whether you're at the bedside, in the hallway, going to CT, or whatever you're doing. But we're going to focus on, again, Bedside Essentials. First up, we have Whitney Gannon, nurse practitioner for Vanderbilt University in Nashville, to come up and speak to us about her experiences with Bedside Essentials. Thank you. Let's please welcome Whitney. And we'll hold all questions at the very end. Thank you.
Hi, everyone. My name is Whitney Gannon, and I'm honored to be here. Thank you for having me. The name of my talk is Patient Assessment Head to Toe, What I Want My Team to Know. And my only disclosure is that I couldn't find many data surrounding this talk, so take everything I say with a grain of salt. One second. Oh, okay. So, like most of the things that I like to do in critical care and ECMO, I think about things in frameworks. And really, to me, when I think about patient assessment in ECMO, I think of four distinct standardized approaches and ways of thinking. One is ECMO eligibility. One is sort of your routine daily assessment. One is an assessment that occurs during acute clinical change. And one is the assessment when, the patient's improving and you're thinking about weaning or decannulation. And today, in my 8 minutes, I'm going to talk about assessment during acute clinical change. So I wanted to start with a case study. This is a 52-year-old man with Legionella pneumonia, ARDS, and severe septic shock. He becomes refractory to maximized vent settings, deep sedation, neuromuscular blocking agents, prone positioning, and receives ECMO. Subsequently, you reduce the vent settings, and vasopressor requirements improve, and the patient's showing signs of gradual clinical improvement. On day 4, you're called to the bedside because the patient is newly hypoxic. So during an acute clinical change, we really need to answer, I think, 3 distinct questions. Is there a new clinical problem? Is there a new ECMO circuit problem? Or is it a little bit of both? Or has there been a management change, either with the ventilator or outside of ECMO or ECMO, that explains the problem? So that would be something reasonable. Or you have to kind of figure out where in the Venn diagram your problem fits. So when I walk to the bedside, this is a very broad strokes framework, and I'll get into this in just a little bit more detail. But the first thing, vital signs. Characterize and contextualize the problem, assemble your team, assess for serious, time-sensitive, and easily identifiable problems first. I think in ECMO, we're really conscientious of the fact that there are a few things that can occur with ECMO that if you identify them quickly and address them quickly, you can save lives and organs. And then you move into your ECMO circuit workup, and then your non-ECMO clinical workup. And some of this can be done simultaneous, right? So the first thing is vital signs. This is a great way to characterize your problem very quickly. And what I mean by that is you ask yourself, okay, and you'll know this very quickly because you're just glancing at it and you can kind of process the data. Which vital signs are compromised? How severe is the compromise? Has the compromise plateaued or does it continue to worsen? Contextualize the problem. For example, so is this crisis management or is this a gradual clinical worsening that you have a minute to kind of think through and work up? For example, if you look at the vital signs and you notice the patient's hypothermic bradycardic, you might already start thinking about the heater cooler. If the patient's hyperthermic and tachycardic, you're already thinking, okay, the patient's metabolic demand is up. Oh, and you really want to assemble your team, get heads, hands in the rooms to kind of help you figure out what's going on. As ECMO clinicians, you could be the ECMO expert in the room. So you really want to take a minute and identify serious, time-sensitive, and easily identifiable circuit problems first. I kind of think of this in 3 questions. Anytime there's a big problem, I ask myself 3 questions, right? Is there blood flow? Is blood flow flowing through the circuit? Are cannulas in the patient? Is there color differentiation, particularly dark blood through the venous and return cannulas? Then, if your answer is no to any of these, you can kind of dig in further. Is there blood flow? No. Is the circuit clamped? Motor failure, power failure? Is there massive thrombosis? You do your circuit check. Are cannulas in the patient? If not, it's been an inadvertent decannulation. Problem identified. Is there a color differentiation? Evaluate the oxygen source. Is there a disconnected gas line, any kind of disruption, a faulty wall oxygen source, or is maybe inadvertently is the sweep gas flow at 0 liters per minute? And then you kind of move through, if all of that checks out, you kind of maybe start to move through your ECMO circuit workup. And I sort of do it in this pathway because it makes sense to me. You've already looked for color differentiation. Maybe the cannulas aren't dark, but they're bright, right? And you might continue through that workup. However, you sort of usually do that. Often your pre-oxygenator PO2 will be greater than the patient's PO2. You might instinctively go to increase your blood flow rate to improve the hypoxia and notice that there's actually an inverse change there. And perhaps you get an X-ray and you notice that the drainage and reinfusion cannulas are in pretty close proximity. Then kind of ask yourself, okay, what is a sweep? What are the settings? What are the parameters? Are they where I had them this morning? Have there been any changes? Sweep gas flow, RPMs, blood flow rate, FDO2, right? Have there been any inadvertent or any intentional changes? Then I kind of focus in a little bit more on the blood flow, right? Maybe the RPMs are set where we had them on morning rounds, but now the blood flow rate is pretty reduced. Is there access insufficiency? Is there movement in the venous line, chugging, chattering? If so, is there intravascular volume depletion, diuresis, bleeding, cannula malpositioning? You're just kind of moving through this algorithm. Okay, now what about oxygenator health? What's the pattern of fibrin formation, clot burden? What are the pressure gradients across the membrane oxygenator doing? The transfer efficiency equation. You can calculate these things to kind of get a sense of the health of the oxygenator. Or just clinically, do you notice that your sweep is going up as your patient's clinically improving? And there's no change in minute ventilation. There's no kind of clinical explanation for why that's happening. And then, of course, you want to do your non-ECMO clinical workup to see if maybe there's nothing even within the ECMO circuit itself that's causing the problem. So just like you do with ECMO, you want to check where your mechanical ventilation is at and make sure there are no inadvertent or intentional changes. Then you also want to look at plateau pressures, tidal volumes and pressure-limited modes. Like, is there another reason? Is there maybe some pathophysiology that's changed in the patient to explain the problem that's occurring? And then, I'm not going to go into this in detail, but you want to do your usual kind of hypoxia workup. You think about shunt, VQ mismatch, hypoventilation. You want to assess for pneumothorax, mucus plugging, pulmonary embolism, new pneumonia, these kinds of things. I really try to avoid kind of focusing in on the ECMO circuit and delaying treatment for something that could be wrong with the patient, and vice versa, kind of focusing on the patient and not identifying that there's a problem with the circuit. They kind of try to go hand in hand. So in the last minute, I'm going to quickly put this case study into context. So, this is a 52-year-old man on VV ECMO, has improved over the last 4 days, and now is hypoxic. So characterizing the vital signs. The patient's oxygen saturations are in the 80s, but they're not worsening, and that's down from oxygen saturation of 98% this morning. Respiratory rate's he's a little more tachycardic. He's a little more tachycardic and he's a little more tachypnic. He's afebrile still and his blood pressure hasn't changed. Okay, so is there blood flow? Yes. Are cannulas in the patient? Yes. Is there color differentiation? Yes. Let's work up recirculation. We don't see any of these signs. The cannulas are in pretty good positioning and we see good color differentiation. What about the ECMO parameters? Sweep gas flow, RPMs, FDO2, unchanged since morning rounds. We verified that. But we do notice that the blood flow rate is a little bit lower than it was this morning. Let's assess the oxygenator health. Well, when we look, we see a worsening pattern of fibrin and we see a new, pretty distinct clot on the oxygenator. So now we're starting to think, okay, maybe we should investigate this a little bit further. We notice a rise in the pressure gradient across the membrane. We notice very low post-oxygenator's PO2 with a high FDO2 moving into the circuit. And we notice that over the past 12 hours, the sweep gas flow has very much increased without any kind of clinical explanation or change in minute ventilation. And so we're pretty sure it's the health of the oxygenator, and that's what's going wrong, but we still want to look at our patient. We notice that mechanical ventilator settings hasn't changed. It seems like the patient's still improving. Plateau pressures are improving. It seems like the patient's still clearing on the X-ray. And so we're pretty certain it's probably the health of the oxygenator, and so we may elect to change it out. So take-home points. characterize and contextualize a problem, look at the vital signs can really help you to do that, identify whether this is crisis management or gradual worsening, and you have a moment to kind of work the problem up, assess for an ECMO problem, assess for serious and easily identifiable circuit problems first. This makes a difference. Then assess for a new non-ECMO clinical problem, assess for changes in management that could just explain the problem. And then, I always encourage to use, it works for me, a standardized and kind of consistent approach or a framework to problem solve for these patients, because there's a lot going on and it's easy to get distracted. Thank you very much for having me.
Thank you, Whitney. This is a very distinguished crowd. I'm delighted to see everybody. My name's Eric Osborne. Our next speaker is going to talk about CRRT and plasma exchange. She's from Belgium. She's an editor of the sixth edition of the Red Book and is ECMO coordinator at a high-volume center. So let's welcome Lynn.
Good morning, everybody. Thank you for the kind introduction. I'm very, very happy to be here. It's been a long time I made such a trip overseas, but this will change hopefully now. To go forward, that's the green button. Yeah. So I was kindly introduced already. A little bit more introduction. I'm from Leuven. Leuven is a university town in the middle of Belgium, and Belgium is really centrally located in Western Europe. So if you plan a round trip in Europe, it's the place to start, because you see we are near to all the great places to go in Europe. So there was a saying, or this guy, Frank Zappa, I don't know if you know this guy, but to be a real country, his criteria are: you need a beer, an air mile, and a football team. So, but at the very least, you need a beer. And then I'm very proud to say that in Leuven, Leuven is home to one of the biggest breweries in the world. Maybe you know Stella Artois. We're also home to the biggest university of Belgium, and this is our mascot. It's Fons Sapienti, which is Latin for source of wisdom. And it's a student pouring wisdom beer in his head. And this is our hospital. It's the biggest hospital in Belgium, the University Hospital of Leuven. So this little introduction to say that's the reason probably why they give me this topic related to fluid overload. So the Bedside essentials, from my point of view as a perfusionist, the essentials related to combined circulatory support, or RRT, and plasmapheresis. Why to do CRRT on ECMO? There's several reasons, but the most common reason is just fluid overload, even without acute kidney failure. Just fluid overload, preventive or curative. Acute renal failure happens a lot in our ECMO patients. You all know this, and these are some data from the literature in 70 to 75% of the patients, leading to CRRT in 30 to 60% of the patients. And some other data even mention 100% of the patients need CRRT. Just to say, you will surely have to deal with this when you're taking care of a patient on ECMO. Essential number 2 is choose the right therapy for your patients. There's different ways of taking over the kidney, or different needs, so it depends a bit on your therapy aims. If it's just fluid overload, you can do hemofiltration or ultrafiltration, so just some convection. If you want to remove small molecules, you can do hemofiltration, hemodialysis. If you want to remove some middle molecules, it's better to go back to the hemofiltration. And if you want to remove large molecules like proteins, you need to go to a high flux filter or a plasmapheresis filter. Just to say, most oftenly in your setting with your patient on ECMO, this will be the continuous hemofiltration modus you will choose. So aim at uncomplicated support. What's uncomplicated support? It's efficient, not interrupted, an optimal device lifespan, blood cell friendly, very importantly, and air and clot free. So how do we achieve it? Which technical options do we have? We have a few different options. You all know the separate CRRT circuit, which you deal with if you don't have a patient on ECMO. So there's not lots to say. It's standard approach, but in case of ECMO, it's an extra access. So if your patient is on ECMO, there's another choice. You can have hemofiltration without a device, but that's uncontrolled therapy, and you're dealing with very high transmembrane or circuit pressures, so you will have a very high ultrafiltration rate. So desirably, you just have to include your CRRT machine inside the ECMO. The only thing is that you're here dealing with non-physiological pressures and non-physiological flow paths. So it makes sense to combine both circuits. Essential number 5 is it's very important to know your circuit and the circuit pressures. If you work with a roller pump circuit, this is a centrifugal pump circuit, but that's a different story. The danger with the centrifugal pump circuit, again, this is something you all know, is that we have a place or a distance where you have negative pressures, which is very dangerous. You have 3 pressure zones: patient pump, negative pressure; pump oxygenator, the highest positive pressure; oxygenator, patient, positive pressure, but a little bit lower than the pre-membrane pressure. And it's the pressures inside your circuit are in relation to a few things. Some things that you can influence, some things you can't influence. The things you can influence is the choice of your circuit, the length of your circuits, the size of your cannula, the type of membrane lung, and then you have also the flows and your type of return and entry vessel. You also have to know the pressure limits of your CRT device. It's also very important. Most CRT devices, you can manipulate the pressure limits, so they're able to work with your ECMO circuit. So where shall we insert the CRT or the plasmapheresis circuit? The best way is at the positive circuit site. Always at the positive circuit site, if I can guide this. Never touch the negative pressure site. For nothing. There's no need to. It should be an absolute no-touch zone. If you have ports, entry ports on your membrane lung, you can use those. And you need to return the blood, preferably pre-membrane lung, so any air that's trapped can be still removed. Also very important, and this is something it's not often enough dealt with, is try to reduce your circuit pressures. And if you're a nurse, you probably won't be able to do it, but talk to the perfusionist. Ask them to build a low circuit pressure system. And they can just adapt the size of the cannula, take a low resistance oxygenator, and it really helps. The lower the circuit pressure, because it is related to the filter longevity, it's also related to hemolysis. So very important, because hemolysis is the last thing you want in your patients, especially our ECMO patients. It's very harmful. You can also fool your CRT device if you need by clamping off to increase the resistance in high return, to avoid the high return, inflow, or the low outflow pressures. As alternative, but this is something I would not recommend, is that you return your blood at your negative pressure site, because there again there's danger for air. Okay, you still can remove your air, but you don't want this complication. And another alternative, which I see, but again, not at all recommendable, is to drain at the negative pressure site. You will not only have a danger for air, but also more CRRT treatment disruption, because every time you suck and there is a shattering, you will have some problems with your CRT device, it will be interrupted, and you will have device clotting and inefficient support of your patient. So we aim at uncomplicated support. I told already how you should desirably insert your circuit and how else can we achieve it. Optimize the anti-co. The best way is to combine regional with systemic heparinization, but you can do both. Avoid very high ultrafiltration rate, which is normal because your circuit will clot, your filter will clot off very much faster. Be aware of ABG contamination. If you use the ports of your membrane lung and you return the blood from behind your membrane lung to before your membrane lung, and you take a pre-oxygenated gas, there might be some contamination. We've seen it, just a little bit thing that you should be careful for. And then aging membranes, it's not because they give less ultrafiltration that they age, but they can also age in terms of clearing less the small molecules. So keep an eye on this one, and desirably you should have a protocol or an algorithm to exchange your filter in time. Do not tolerate rising plasma-free hemoglobin. If you see this, ask somebody to come and have a look at the circuit. You should never tolerate it because you cannot remove it with your filter neither. And if you do plasmapheresis on a VV ECMO, it might be that your patient becomes a bit hemodynamic unstable, so this is something that you could watch also. So to finish off the future, what's the future? There's not much future in the combination of the two. But what I've seen, this one paper I've seen, and it might be very, very interesting because we very much often use the two techniques together. And it is this membrane that some engineers are working on. It's a group of Europe. And it's a combined gas exchange and filtrate membrane. So it's a combined hemofilter oxygenator. So that would be nice, but this is just the first brainstorming and a prototype. So maybe we'll see this on the market in so many years. So in conclusion, ECMO and CRT, it can be a healthy marriage if the shortcomings of both characters are understood, recognized, and considered, but that's just like this in any other marriage. And for more information, there's a whole chapter on this in the Red Book. Thank you very much.
Great presentation. So Aaron, our next speaker, is not present, so we're going to skip to Jane Mandrake from Australia. She flew quite a few time zones here to get here. Excuse me, I stole that joke from someone else. So Jane, please come on up, and welcome Jane, please.
Hi everyone, thank you very much for this kind invite. I'm Jane, and as David said, I come from Melbourne in Australia, and I will talk to you today on awake ECMO patients. I'll just wait for my slides. I don't know about anybody else, but whilst we're waiting for my slides, when I first came to one of the conferences and they talked about awake ECMO, they would show a picture of a patient walking around. And I'd be thinking, I'm not sure how many people do this. Not in my hospital, maybe one in 100 years. So when you're thinking about awake ECMO, just have a think about what sort of patient group or the patient that it makes you think of. I have no disclosures, and I have all consent from media. All right, so that is a video of a patient of our patient that's a VA ECMO patient that's got FEM-FEM configuration and that's walking around our unit. So that patient is a lady who's awake, active, and mobile. And when we think of awake ECMO, there's these three dimensions that we need to think of. There's a few patient cohorts that really are sort of specific to the fact that you could maybe potentially have the patients awake on ECMO. The bridge to transplant group is a group that's got some established papers or case studies, but we know from looking at that group, that's a group that works well with awake ECMO. I'm sort of going to throw a little bit of a devil's advocate and sort of short-term ECMO, do we really need to wake these patients up? If you've got someone who's going to be awake, you're going to be off ECMO in 2 days, are we going to spend a lot of time and resources to make this patient awake, active, and mobile? And then you've got the VV group. So you've got ARDS, and then, of course, as we all know, we've got COVID. Here's just a few papers looking at those patient groups. And we'll focus probably more on the practical components of VA and awake ECMO. This is one of the initial or pivotal papers when we're looking at mobilising ECMO. And I have the pleasure of working with Carol Hodgson, who is the author on this paper, along with Eddie from Toronto. This is a paper that was published last year from the Chicago group, looking at mobile ECMO. This group looked at ECMO and awake ECMO and used a standardised checklist or assessment tool to work out which patient group was best to be able to apply awake ECMO. So we're all striving for these different dimensions, and we're trying to move our patients from this awake to active to mobile. But how do we get there? This is sometimes really difficult to achieve. Often there's lots of patient factors: delirium, sedation. And then we look at the patient each time. So when we're thinking about our patient, I can guarantee when the ward round come around, the patient always looks neat, tidy in bed. And as soon as the round have left, they look like this. So when the ward round come around and say, right, we're going to get him up today and mobilise him, and then you turn down the sedation and they look like crazy, you know, it makes it a bit tricky to work out what you're going to do. The caregivers and the ECMO staff are the real thing that we need to look at and focus. It's great to have an awake patient. Let's have a look at some of the things that, some of the factors that will make that difference. This is the ELSO guideline for extubation of a patient on ECMO. It's a pretty great guideline. It's pretty simple. There's not lots of stuff there. But then remember that this is just one component of all the other stuff that you need to put together to get this patient awake, not agitated, not pulling out the lines, safe. This group looked at awake patients, and one of their criteria, they used a checklist, which is great, or a tool. And one of the checklists that they looked at was exemption of patients that had a high risk. They're a high risk classed as someone who was unable to clear secretions, had an impaired mental ability, or GCS, and had some inotropes. Now, I don't know about you, but that's probably 90% of my ECMO patients most of the time. So what I'm trying to say is it's a really limited or small group occasionally. And then you've got to look at our staff. We've got because of the pandemic, we've had lots of staff and lots of training, just like I'm sure everyone else. But it means that, again, when we go around and we make these plans, we need to make sure that we have support for this staff by the bedside to be able to deliver the care that we're asking them to deliver. We need to make sure they've got exposure, time, and clinical support. Who's going to help them with the roles? Who's going to help them with the lines? When's someone else going to help them if they're going on a tea break or when their physios are here? That's not me, I promise. You've got to get the team together. There's not just the nurse by the bedside or the caregiver. You need to get the ECMO specialists, the physios, the RTs. And I don't know about you, but for me, trying to get all that group together, it's like rounding up sheep. And then you've got to find the actual time. ICU time, I say to relatives, whatever ICU time we tell you, double it and add 10 minutes. We always tell people we're going to be 10 minutes, and we're always way longer than that. So when we're planning these things, to make them safe, we need to make sure that we've got enough time. We can achieve things. And one of the pivotal things for this picture for me is the fact that this patient is awake, not particularly active, but is able to interact with his family, which is really important. This is one of our patients that was a COVID patient that's on telehealth with their family. So isolated, but still able to interact. So how do we overcome those challenges? Well, we could look at some tools and checklists. Now, I know people talk about checklists. You either love them or you hate them. But there's no actual checklist for looking at how we wake up these patients. There's one for extubation. As I said, the Chicago group have got one for mobilising their patient, but there's not one for the whole bundle of care. We need to aim for the highest for the patient at each interaction. So what I mean by that is, When you come on the ward round on Monday and the patient's awake, that's great. We get him up, we walk him around the unit. On Tuesday, he's worn out. So we need to think of what's best for that patient or what we can achieve that day. Or as I said, you have the ward round that come in the morning and the patient's looking fabulous. You turn down the sedation and they're doing crocodile rolls in the bed. So, you know, keeping them safe is not, awake is not safe. Agitated, pulling their lines. I can see people nodding, we've all been there. I think the one that's biggest bang for our buck is education for the staff by the bedside, regardless of what discipline it may be, and how we work together as a group to make sure that they have the most clinical support. So who is going to help this team get this patient awake? Do we have sedation protocols? Do we have a team of physios or RTs that are going to come and help us do these? And also we've talked lots in this conference about staff well-being. So making sure that we look after the staff by the bedside so they can continue to look after this patient group for a long time frame. And of course, as I said, the collaborative approach, everybody working together, and particularly the patient's family. So we need some more studies. Well, that's happening. There is some stuff out there, and it's encouraging data, but we need more. Most of the data out of there is case studies. We need some more evidence. We need more support. As I said, well-being-wise, that is happening. We just need to be kind to our staff by the bedside. Give them more clinical support, which is hard, I know, because all of us are stuck with trying to make sure that we've got people there. But together, we can do great things. Take-homes, we've got lots of encouraging data. I haven't got anything mind-blowing for you, but just do the things that you're already doing, just do it a bit better. 5 years ago, none of these things were possible. You'd all have looked and gone, you're all crazy. Now we're all going, yeah, I can do that. Let's just work together and do the things better. Maybe adding in a protocol, a sedation checklist, the extubation checklist, you know, having more interaction on the morning round so we can achieve the better for the patient. Again, looking at that specific cohort, it might be that your VA patient that's going to come off tomorrow is really the one that you go, actually, no, we don't need to spend our resources for this patient. As I said before, best patient time frame. So what's good for the patient yesterday might not be the best for today. So setting those realistic goals. And again, the most important, education and support for our staff. Together we can all do some things like this. This is one of our patients that got married in our chapel. And I hope this video works. Oh, yeah. And then this is one of our other patients, one of our 100 patients that's walking around our unit. Thank you very much.
Thank you, Jane. Jane, I'm sorry I butchered your last name a minute ago. So next up, we have Aaron August, is the adult ECMO coordinator from Memorial Regional Hospital down in Hollywood, Florida. When I was reading her bio just a minute ago, trying to get everything correct, and I saw Hollywood. So wow, because Aaron was really fashionably late a few minutes ago. But Aaron, that's the wrong Hollywood. So you may want to work on that. But anyway, please welcome Aaron August to the stage. Thank you.
Really, it's just trying to remember how to walk in heels again. All right, thank you for your patience. My apologies. So today I'm going to talk to you about something that hasn't been talked about a whole lot, and that is the skin. The skin is the largest organ as we know, but it's also the most forgotten, even though it's impacted by low oxygenation and poor perfusion from the very beginning. First impacted, last thought of. So I have nothing to disclose. And you see here what we have for our objectives. I want to understand the vulnerability of our patient population. What I just spoke of about the first one impacted, vasopressin, arch enemy of the skin, anticipating patients, that nutritional status. We need to pay a lot more attention to having our nutritionists on board, and challenges that are unknown with health history, as well as just the overall critical state of an ECMO patient. So we know what the most common elements are, especially from a nursing perspective. There are physical things that we need to think about as well as mechanical things to think about. My colleague that spoke before me addresses exactly one of those, which is immobility. There are many other things to think of as far as what we think about with nutrition, incontinence, medications, hydration. There goes on, all leading into breakdown, which leads to HAP use, which makes unhappy administration. Our friends at the TJC don't like to hear about HAP use either. So you see they have that as a national patient safety goal that we need to address. Sorry. So, and at the very bottom, this statement's very important. As you see, 30% of these cases are related to a hospital-acquired pressure ulcer from what? Medical devices. That makes them not like us. So we need to do better about paying attention to the skin. Also, when you start to include our friends that are the CFO and Director of Finance, you see they don't like to see this either because you see the very large price tag that comes with developing pressure ulcers and other infections while these patients are in the hospital as another part of their complication. So, HAPUs are a financial concern, as we know. Look at the cost, $500,000 to $70,000 per HAPU. It also increases our length of stay, which we never want to see. And if these people become septic based on a HAPU, guess what? That's a longer ECMO run for us too. So here's the incidence of a HAPU within an ECMO population. In the last study that I was able to find, 29.5%. So again, going back, we must always consider the risks, including age, nutrition, vasopressin use, and more. So also education of staff and making them feel comfortable. As my colleague before spoke of, it's important to make sure that everybody feels comfortable and the team is all on board and everybody is trained appropriately to turn patients. If not, bad things happen or the turning doesn't happen at all. So here are additional things that I did not mention in the beginning. So hemodynamic instability, nursing apprehension. Again, nursing apprehension. Everybody's afraid to turn because they're afraid to pull a cannula. They're afraid to disconnect the circuits. And also we know if they're in a hemodynamical state which is not doing very well, we're having to go up on levo, go up on vaso. If we turn them the slightest bit, their blood pressure drops. You know, there's things that we do even now that we can even tuck pillows, things like that. It's very important that we try to offload pressures to try to do our best to try to keep the patient stable, because unfortunately, as much as I hate to say it, we all know that sometimes if we turn, we die. We have to figure out a way that we can kind of help combat everything all at once by looking at the bigger picture. So the Braden scale is a tool that's used all the time in nursing care, along with a turning schedule. Staging of the ulcers, as here, as we're all very familiar with. And showing you a little bit of the pressure points when a patient is lying in bed. I know any of you that have been down to see our exhibitors have seen some of the great new beds that are coming out that'll help assist our patients, including helping them stand while still in a state of weakness. Here are preventative measures. So think about nutrition. Think about your bed. What type of bed do you need for your ECMO patient? Do you need a bariatric bed? Do you need an airflow bed? Do you need, there's so many different specialty beds that we have now. Even the dressings we can use. A dressing doesn't always have to be for a sore. It can be as a preventative measure. We like to use Mepilex. It's a very good product to use or to consider in addition to what you may be using already at your facility. And getting them mobile. So mobility protocols are highly encouraged, just as my colleague before me spoke about. Staff education, ECMO team coordination, knowing all the factors, what is my risk and benefit of doing this for my patient? I need to do everything I can to bring down apprehension on all aspects in order to do what is best for my patient. There's the specialty beds I spoke of. There's so many. And also, too, we use Hoyer lifts that are based and they come down out of the ceiling, so we're able to even turn the slightest bit. You know, there's also these slides to help with the shear. Here's the dressing I spoke of. And now also, too, wound care consultations. Our wound care team should be used a whole lot more. Our skin care nurses should be used a whole lot more. We should start this from the get-go. Start to assess them right away, especially if you are an ECMO program with a transport team. You don't know what that other hospital's protocol was that you're receiving the patient from. So it's really important to start from the get-go, to start to look and see what you can do to best optimize the outcome of this patient. Again, I referred to nutrition. So always be prepared for the unexpected. We can always learn more. Sorry. Cannula care. When we talk about our cannula care, it's always important to make sure that we are constantly assessing those sites. For us, we use a transparent dressing that we're able to assess the site at all times. For us, less is more. In addition to that, I have taught my team how to make sure that they look and they care for suture integrity. We make sure that we discuss with our intensivists and surgeons every time we think that there's a concern of something being loose when we change our dressing. We know, as we had talked about with CRRT, about fluid removal, our ECMO patients shift fluids a lot. You can have a patient come in that's 60 pounds of fluid overload. What are those sutures going to be like 60 pounds later when you're removing it, right? So you've got cannula in there, high RPMs. I don't want my sutures to be loose. So suture integrity, making sure that you are constantly evaluating that is key. So here's questions for the group. So, knowing this is a complication of an ECMO run, or also when you receive a patient from another facility, should we look at adding skin to the complications of the registry? We see we have all these other things. There's many different ways we could think about doing this because skin does cause all kinds of complications. In addition to, if they're sick enough or the wounds are bad enough and the patient becomes septic, think about how our stratification for listing for transplant is now. ECMO is number one. It puts the patient at the top of the list. That could be good, that can be bad, because also at the same time, if we don't manage the skin and keep these types of breakdowns down, you may cost a patient their opportunity. So from a coordinator perspective and being a nurse by trade, I always think about dressings. I was a VAD coordinator before I became an ECMO coordinator, so through these entities, we always look to try to do the best things and come up with best practice as far as site care. So is this something we as ECMO coordinators need to come together and start to look at as a group? Do we need to start to consider standardization of doing these types of dressings? We also need to talk about different ways of cannulation and what people are doing, whether their patients are immobile or mobile. So I would ask you right now with a show of hands, how many of you have mobile ECMO programs? How many of you have standardized dressing protocols for your ECMOs? How many of you secure your cannulas on your mobile patients by means of grafts? A few. How many of you have problems with skin degradation with the cannulas turning and things? So see, there's a large number of differences with things. So I think that maybe this may be a project that we may need to consider for the future, especially too, if we're using these and having longer ECMO runs, whether it be for recovery or for listing for transplants. So in summary, as you can see, treatments lead to increase of pressure injuries due to cannula fixation, sedation, positioning, and decreased perfusion. All of these things we need to think about. Even like how we secure our cannulas. You know, there's so many things that we can talk about and start to develop these best practices. We'd love to be able to get our ECMO patients up and walk them more, do more for them, and have them have less complications. We as healthcare providers want better outcomes from our patients and lower lengths of stay if it's possible. Fluid shifting and hemodynamic instability, that is always a challenge with these patients based on the reason that they were put on ECMO. So we know vasopressin can be a friend, but it can also be a foe depending on how long we have to use it and what does it do to our skin. So, and again, the last statement, flipped on its own, I apologize. Despite current evidence base, as you can see, the references that I used, there are not many that fall within that 5 years that we as scholars are supposed to use. So there's a lot of research and best practices we can develop because the literature that's out there is old and scarce. So I encourage all of you, if you're looking for some research, the skin truly needs some love. Thank you.
Thank you, Aaron. So our last presenter is Bradley Kutch. He sits on the ECMO LSO steering committee as an RRT liaison. Yeah, a fellow snot sucker. Thank you. Bradley is an ex-ECMO coordinator. He's a director of respiratory and transport at Stat Medivac. Is that correct? I've been to Bradley goes. We talk about old and new friends. Brad and I go back probably at least 24, 36 hours now, probably. So, yeah, exactly. And he wasn't wearing glasses the others. I think he wore glasses to look smart, so we'll see what happens. But with no further ado, please welcome Bradley Kutch. Thank you.
Hello, everyone. I'm absolutely thrilled to be here today. I have the honor to talk about two of my favorite things, ECMO and transport medicine. So as my introduction kind of came across, I started my career as flying a helicopter, picking up sick kids, had the honor of building a neonatal pediatric ECMO program, which was more for salvaging kids that were stranded on ECMO, and as the ECMO coordinator and researcher. Then came back as the director of the pediatric transport program, which I was allowed to build, market, and brand. And then my most current role is as director of medical operations for a system that does about 50 ECMO transports a year. In full transparency, I am only learning adult medicine. I tell everybody I'm really good at the little people. The big people, after reviewing charts, blows my mind, so I'm learning, so be gentle with me. So I'm really happy to be here and talk about two things that are very important to me. My approach from this is to really talk about the parts of transport, ECMO transport, that are often forgotten using the dynamic environment that is transport medicine. So when we go through this, we will really be talking about those challenges that we can address that will make that transport go a lot easier and will decrease our risk of complication. So the first thing, I love this quote. I don't know who wrote it, but I use it in a lot of my talks because I think it's maybe one of the most important things when you think about the transport environment. Perhaps there is no element in the continuum of critical care services that is less understood and more laced with monocular bias than the transport of patients to and between hospitals. I could not agree more. And then we throw a very complicated life support device on top of it where blood's outside the body and we have lots of challenges. So the approach I'm going to take with this is really about taking a couple different areas and talking about how they impact us as ECMO specialists, perfusionists, and really ECLS professionals. So patient severity is one consideration, crew configuration, mode of transport, which we'll really talk about. In those mode of transports, the space configurations and what that's going to create. So how many people are we taking in a vehicle? Do we know the vehicle? What is the vehicle's capacity? And as I had a lot of conversation over the week, please understand there is no one mode of transport that fits every patient in every clinical situation. So I've been personally on transports where I went to helicopter to a location, into an ambulance, to a fixed wing, and back. It's happened. Those situations, you have to be set up and ready to move that patient in a safe and effective way to another mode with impact or increasing the risk of a bad outcome. The second part of it is flight physiology. I'm a respiratory therapist. I do nerd out about gas laws. I'm going to talk about two of them. The next part is environmental challenges. And when I talk about environment challenges, I'm going to be talking about challenges that impact you as somebody that may not be an aviation person, but now you're in this dynamic environment. And maybe just as important, if not more important, is that impact on the patient, that stress of sound, that stress of vibration, and what their vital sign impacts are going to be. And I want everybody to understand the goal of any interfacility transport or transport service is a timely and safe transport without an increase in risk of mortality. Safety first for everyone. Okay, so I put these two together looking at this, and this is about the decision making. So these are a couple areas that when that initial piece starts, how do we look at the picture? Now, I'm going to go in a little more depth when it comes to severity and information gathering from the ECMO piece. But when we think about this, we need to understand what is the patient that we're bringing into our institution. Who accepted the patient under that service, and were all the right questions asked? So, as an ECMO specialist, I would really want to know, when was ECMO initiated? Was it in the cath lab? They had cardiovascular failure. Boom, they put them on, they perked, and we need to go now. Or has the patient been sitting in ICU for 12 days, and they're at a spot that we need to consider transplantation, and we need to move them? Two very, very different sets of situations. Moreover, who's moving the patient? Is it your hospital-based team, or is it an academic flight service like I have that moves many patients from many hospitals lots of times? The next part is VA versus VV. Very much matters. Pump type. What am I working with? Am I going into a roller pump situation? Where am I going? What am I going to do? Because those individuals are going to be in charge for maintaining that and moving that, need to have that information. Duration of support, circuit status, cannulation site, location, oxygenator gas. Very important information. Patient's on for 12 days. Is that oxygenator still transferring gas? And we'll talk a little more about that. And then finally, blood product consumption. All of those are questions that should be asked, and we're going into a little more detail. Now, crew configuration. This is more of a question for you than a true answer. So as I put in that first quote in the beginning, there are many team configurations. We were talking with some colleagues earlier, and I mentioned that when I was the ECMO coordinator, because I had flight experience, I got to go as the flight therapist, the ECMO specialist, we had a nurse and a doctor. So I got to maintain the ventilator and transfer the circuit over, maintain all the blood products, all in one trip. I did 4 of them that way, and it was plenty. So how your model fits, it's really in the need of the patient. So I put up here RN, RT, perfusionist, with or without a doc. Our service moves lots of patients once they're stable in ECMO, no physician. My pediatric side, different group, we took a fellow with us all the time. Patient care needs, procedures, and maybe more importantly, predicting the needs of that patient. What is our approach to this? And this is not a transport team discussion. This is the perfusion group, ECMO, and transport team discussion. That team will know X, the perfusion group will know Y, and you have to put them together to understand this. Understand crew model limitations, what are the limitations of that? Crew resource management, communication, and the one thing I noticed about all these talks, which I applaud this group, is everybody talked about teamwork. It is teamwork, and we need to communicate, and that's really, really important. So I did put underneath their equipment list. So anybody in the transport realm, anybody that's done ECMO, we all have those people that carry their own stuff, their own time. Now, if they pack that bag and you end up doing the next trip, you may not know what's in that bag. So that's crew resource management too, standardization. And finally, space limitations. I keep forgetting I have the clicker in my hand. That double click? Oh, pre-port, and I just want to go in a little more detail with this. So at the time of referral, so you know that this patient needs to come in, we need to engage the ECMO specialist, the coordinator, however you decide, someone that can gather that data, chief perfusionist, fellow CT surgeon, someone that knows how these questions to ask. So the first one, include that ECLS team. That can even be, yes, we accept the patient, we're going to call you back in an hour, bringing a team together and do a quick moment. Now, it depends on the clinical situation. Information gathering, we talked about VA versus VV, pump type, duration of support. What are the risk of clots? When I talk about the dynamic environment that is the transport environment, those clots have a high likelihood of moving. So as an ECMO specialist, when you come in, the first thing you should do is do that circuit check, walk up and down it, understand what things are going on, and move through that process and communicate. Where do we need to go from there? The next part, cannula size, number, and location. I was talking to somebody earlier, and they said, and we were sharing experiences, and they said, yes, I walked in, and we just thought it was a straight VA ECMO, and there was a VA ECMO, there was a bunch of drains in the chest, all this stuff going on, and that changes your approach. So being able to understand that. Also, the ECMO specialist and perfusionist know the flow limitation of those cannulas by size. There's not going to be a transport team in the world that's going to understand that flow limitation. In addition, we need to understand the pressures. You know, how is that working? Is the cannula sitting right? Do we need to look at the chest films before we go? Oxygen gas, we talked about. Active bleeding sites, that can be a big one. You need to pregame with that. Also, I will tell you, the blood product administration is a problem. Depending on your state and what their state laws are, you may not be able to cross the state lines with blood from inside the institution. You need to know that so you don't get a nice little subpoena in the mail. The next part is hematologic status, which we know, and then lung and cardiac function. So the point I want to put with that is, if I go to pick up a patient and there is no lung function, I know immediately there's no margin of error. I'm not going to bag them up, be able to fix them. Same with the cardiac. So understanding, hey, we have a good pressure waveform, or you know what, the ventilator's doing okay, it's open, we're just almost there. Those are all things you need to ask, because when a problem happens, which you need to be prepared for, you know how to move on it. Mode of transport considerations, pace constraints. How many people are you taking? Where are they going to fit in? How many bags are we taking? Where does my pump go? It all matters. So I can tell you the difference between 3 or 4 different helicopters is significant. One helicopter might be the Saab. I hope you guys remember what a Saab was. I'm kind of dating myself, but maybe like a Saab, and the other one may be like an Escalade. Lots of room, lots of details, lots of big. Understanding what your space is important. Lift versus seating versus workability versus distance. All of them go into that. So when I say lift, believe it or not, there is a weight constraint on a helicopter. So if it's in the summer, you're going to be able to lift X and you need to weight and balance. In the winter, it's Y, and you need to understand that so you can make the right selection, because truly, very few services have the same number of helicopters and type of helicopters across their whole piece. What's the distance for transport? Do I need to refuel? It is not ideal to need to land a helicopter with a patient and decide to refuel it. So you need to talk about that. Landing considerations. I've made very difficult decisions in cold weather to go by ground instead of helicopter, because it's so cold on a helicopter pad that those plastics, which we'll talk about, become brittle and could break. So we had to go by longer route to make sure the patient was safe and we could go indoor to indoor instead of on top of a helipad. All those considerations need to be looked into it and understood, and that's where your team has good dialogue. Multiple vehicle platforms, I talked a little bit about that. What am I getting on the other end? So depending where you fly in and out, if you use a fixed wing and you have all your equipment set up and it works great in your hospital and in your ambulance, when you land at an airport, that service that's coming to you will not be the same. So is the inverter powerful enough? Do I have blended gases? Do I need blended gases? Is it a true sine wave inverter? Because a non-sine wave inverter for a medical piece of equipment will blow the fuse, and that's a whole other discussion that happens, and it's not good. So understanding all that, I have down here also, will my stretcher fit? A lot of different configurations exist with those stretchers, and you don't want to be moving a patient that's connected to an ECMO circuit that has lines everywhere and moving them. Where will my pump go? That's a big one. What pump are you using? Where's it going? And where am I going to store it that it'll be safe and accessible to that perfusion professional? Flight physiology, I promised you only 2. I'm not going to read these laws verbatim. I enjoy gas laws. Basically, Dalton laws means your PO2 will drop as you go higher up in the air. So a lot of aircraft can actually be pressurized to much lower than, say, 3,000 or 5,000 feet. So you just understand, why is my PO2 dropping? It's just the nature of the game. You may need to do different things. The other one is Henry's law. Small bubbles will grow with increased altitude. That's because your barometric pressure drops, and that bubble is going to get bigger. So when you look at that arterial line and where the tubing's connecting in and you see a bubble and you say, we're good, you may want to think a little bit about that, because with the vibration and the change, that bubble will migrate. So all those are considerations that are ECMO specific that will decrease the risk of a poor outcome during transport. Understanding these principles will help with potential defects or untoward events as well. Environmental challenges, and many of these are not just to the patient, but the crew as well. And they are significant, and you need to think about the environment. So the first one is transport environment is dynamic. It will change, it will constantly change, it will have effect on your circuit, it will have effect on the patient, and it will have effect on you. So things like change in barometric pressure, which we touched on, but also vibration. The vibration makes you tired. So if you got an 18-hour transfer from halfway around the country, you better believe you're going to be tired when you get in there. The next part is sound stress. It impacts the patient. If they are not sedated enough or if they're not comfortable, they will feel anxiety and stress with that vibration and sound. And that's legitimate. That heart rate will come up. It will impact your blood return. That is real. Temperature, major issue. Extreme cold increases the risk of plastic fracture. So I just want everybody to know those plastic connectors that we use, if they're pigtails or if they're connector pieces, they're designed for inside the hospital. 70 degrees, 72 degrees, somewhere between 60 and up to in the 80s. When you take them out and it's 15 degrees or sub-zero, that plastic becomes incredibly brittle. And if you just bump it, which it normally would take, it may fracture. And depending on what side of that circuit it is on, you will entrain gas or you will have a, as I call it, blood squirting emergency. So understanding that piece will decrease the risk. Affect patient temperature as well. So, when you have these circuits, circuit size is going to matter. If you're taking a lot of blood outside the body, you will drop that patient's temperature exponentially. The effect will be greater the smaller the patient is. So if you have a smaller patient and you have lots of tubing, regardless, you may affect that, that patient's temperature. Now, many standards we do have to monitor temperature on transport, that should be taken care of. The other part I want to talk about is the pinch point plenty. I tried to be a little clever there, but there's a lot of them. Folding legs, doors closing, all kinds of things. So my goal and the best practice that I can find truly, have that circuit inside the footprint of the stretcher. Where that pump sits and everything's inside it, wrap them up in their blanket and go, and it'll decrease your risk of causing an issue. So I just want to conclude with some take-home points. First of all, the transport environment is dynamic and all aspects need discussed, communicated, identified, and make sure you have a plan around it. So when I say that, what the ECMO transport environment is, it's special, it's significant. We have to have teamwork to keep with our theme. We have to have teamwork and communication. These transport service professionals do not have the skill set to ask the questions, to understand what the hematologic pieces are. So we have to partner with them and build a process to be able to do that if you're a hospital-based piece. Crew configuration should be standardized. What works for the group? Who are the ones? Don't make Brad be the therapist and the ECMO specialist on a transport because it's very stressful, and that's why my hair's a little less over here. Prepare for multiple vehicle transfers. Understand what those legs look. As the in-hospital perfusion person, you're not going to know, but ask the question. Are we just doing this by this, or how are we doing it? Include the specialist. So if you're part of this and you're designing this program, make sure you have what I call a hot wash at that call. So call comes in, patient's accepted, let's ask the right questions, let's build the plan, and include those ECMO specialists. The next part is consider the silent potentials for complications. Environment, gas laws, equipment needs, and most notably, nothing lasts forever. So I started my transport career and ECMO career when batteries lasted 15 minutes. So you were literally sprinting to where you go, and sometimes I carried a marine battery that I could plug into. This is the truth. Now, we have much better batteries, and it's a little bit better. But oxygen, battery, fluids, blood will not last forever, so keep that in mind. And then food for thought, ECMO specialists trained to the circuit and pump for a smooth handoff. Now, what we did that was incredibly successful for us is when we used a particular model, we made that it was transport, okay, so the same pumps, and then when we came back to the bedside, we could take the head off, put it back in, and spin it right up. And those ECMO specialists at the bedside, everybody was consistent with it. So it was a cross clamp, put the head back in, spin it back up, move over your gases, and you were gone. And then you could do a good handoff. Nothing's really changed. RPMs are good, flow's good, pressures are good. You're on the same page. It is cumbersome to take a pump that's acting a certain way and put this patient on another pump, cross clamp and do everything because things change. The more consistent you can have as a group, the better off you'll be. So I just want to say a big thank you. I love seeing the room so full, and this has been a great meeting, so I want to thank Elso for this. It's been great.
Thank you, guys. If you have any questions, you can come to the table here and ask. It's lunchtime. I'm sure you're hungry, so enjoy, and thanks for your attention.